Hi, I am Dr. Anil Satyaraddi, consultant endocrinologist at Bagalkot. I'll be discussing one case which we will be seeing commonly in our clinical practice. A 50-year-old gentleman who is a chronic smoker having type 2 diabetes mellitus for over the last 10 years and hypertension for around 10 years, for which he has been on tablet glimepiride with metformin at a dose of 1 milligrams bar 500 milligrams twice daily and tab telmisartan 40 milligrams once daily for this comorbidities. So 3 months back, he had a chest pain. On evaluation, he was found to have coronary artery disease on coronary angiography, and there was a blockage, around 90% blockage in the right coronary artery, and he was diagnosed to have a single vessel disease. He was also having low ejection fraction of around 40%. So he underwent an angioplasty around 3 months back, and he has visited to the OPD now. He is also on medications, beta blockers and antiplatelet medications, that is clopidogrel and ecosprin for his coronary artery disease. He has also been prescribed statin medications. On examination, his blood pressure was 130 bar 70 millimeters of mercury, weight of around 80 kg with body mass index of 31 kg per meter square. So his biochemical investigations for evaluation of his comorbidities and complications of diabetes revealed fasting plasma glucose of 200 milligrams per deciliter, postprandial plasma glucose of 230 milligrams per deciliter, HbA1c of 10%, serum creatinine of 1.5 milligrams per deciliter. His estimated GFR was 60 ml per minute. His lipid profile revealed LDL cholesterol of 180 milligrams per deciliter with normal HDL cholesterol and serum triglycerides. His urine microalbumin was 100 micrograms. His eye evaluation was done to look for the complications of diabetes mellitus, which was suggestive of bilateral moderate non-proliferative diabetic retinopathy. He was also having mild bilateral symmetric distal sensory neuropathy. In a gist, we are encountering a patient who is 50-year-old, who is a diabetic, hypertensive, and having cardiac complications in the form of coronary artery disease with low ejection fraction, who is obese and having microalbuminuria, and also the other microvascular complications of diabetes in the form of retinopathy and neuropathy. So let's discuss how to manage this case. So as we know, we have to target lot of comorbidities in order to improve his morbidity and mortality, as it has been shown in one landmark trial, which is a steno trial, which showed that if you do multifactorial risk reduction, then only you will be able to reduce the mortality as well as the morbidity. That means not only the glycemic control, but also the control of blood pressure, other comorbidities, and also control of hyperlipidemia is very important. So in our patient, the blood pressure was normal, so he was asked to continue angiotensin receptor blocker, that is telmisartan, at a dose of 40 milligrams once daily. And it has been proven in the lot of clinical trials that the ARBs are better in diabetic patients and also in those patients who have microalbuminuria. So for his dyslipidemia and the coronary artery disease, he was already on beta blockers, antiplatelet medications, and also the statin therapy. So coming to his glycemic control, so he was advised about a optimal diabetic diet, for which we usually recommend to avoid high carbohydrate diet and to increase the intake of the protein diet. And also we will ask him to continue his regular physical activity, that is around 30 to 45 minutes of moderate physical activity, which should be done for at least 5 days in a week to show a potential clinical benefit. So coming to his glycemic control in the form of medications. So for this patient, we have lot of medications for his control of glycemic in diabetic patient. However, which are the best medications which can be used particularly in this patient and in this setting? As we know, there are a lot of changes which have happened according to the newer guidelines, that is either American Academy of Clinical Endocrinology guidelines or the ADA guidelines, wherein they have suggested that particularly if the patient is having any cardiac complications in the form of coronary artery disease or a renal dysfunction, the SGLT2 inhibitors and the GLP-1 receptor analogs will be a very important and the best drugs, particularly for the management of diabetes mellitus. So in our patient, the SGLT2 inhibitors will have an edge over the GLP-1 receptor analogs, because in our patient, he had the cardiac complications in the form of coronary artery disease, for which he has undergone the angioplasty, and also he was having a low ejection fraction of around 40%, and also he was having renal complication in the form of microalbuminuria with mild reduction of the estimated glomerular filtration rate. As we know, the SGLT2 inhibitors, in particular the empagliflozin, which has been shown in a landmark clinical trial, that is EMPA-REG outcome, wherein the usage of empagliflozin in a diabetic patient, it reduced the risk of MACE events, that is major adverse cardiovascular event, hospitalization due to heart failure, and the cardiac death by around 1/3. That is, the risk reduction was in the range of around 30 to 35%. So in this perspective of our patient, the empagliflozin will be a vital drug and the best drug for the management of hyperglycemia. A word about the DPP-4 inhibitors. As we know, the DPP-4 inhibitors are also a novel therapy for the management of diabetes, and there are a lot of drugs in the market like vildagliptin, sitagliptin, saxagliptin, and linagliptin. A special mention about the linagliptin because of its unique characteristics. Being a DPP-4 inhibitor, this linagliptin will have a biliary excretion. That means it can be safely used in patients who have renal dysfunction. And also the usage of linagliptin in diabetic patients who have the renal dysfunction, particularly in the Carmelina study, had shown that the usage of this linagliptin was able to reduce the risk of albuminuria, and also it reduced the progression of renal dysfunction in diabetic patients in this clinical trial. So now we have said that the SGLT2 inhibitors, that is empagliflozin as well as linagliptin, both are efficacious in reducing the hyperglycemia, and also it reduces the renal dysfunction, and also they are more cardiovascular beneficial. So a novel therapy, if you combine these two drugs, that is a combination therapy of empagliflozin and linagliptin, which is also available in the market. So the usage of this combination therapy, that is empagliflozin and linagliptin, one, it is highly efficacious in reducing the HbA1c because it targets the various pathophysiological pathways which are involved in the omnious octet of the diabetes mellitus. 2, the usage of this combination therapy reduces the renal outcomes. 3, The advantage of using this combination therapy is it reduces the risk of complications which can occur with the SGLT2 inhibitors. That means the usage of this combination therapy, it reduces the risk of euglycemic ketoacidosis, and also it reduces the risk of genital mycotic infections and the urinary tract infections in clinical practice. So overall, to say that a novel combination therapy of empagliflozin and linagliptin have several uses and several benefits which can be used in a lot of diabetic patients who have cardiovascular complications and renal complications. Thank you.